Welcome to the Transforming Lives panel, the podcast where inspiration and transformation converge. Each week, we come together to explore the depths of personal growth and life-changing experiences. Come along with us as we deep dive into personal stories. Through intimate conversations, our guests and panel reveal the pivotal moments that have defined their paths, shown their strengths, and formed their passions. We are so happy you are here, and we welcome you to our circle where empathy and empowerment are always at the forefront.
Welcome to another exciting episode of the Transforming Lives panel podcast. I'm one of your hosts, Sharmin, and Mitzi is here with us, and we also have a guest. We're going to start today and just ask you to take a moment, the next 45 minutes, to be present with us. And I'm going to leave you with a quote that is suitable for the discussion that we're about to begin, by Emily Dickinson. And the quote reads, "The brain is wider than the sky." Dr. Heath, thank you for embracing us with your presence and agreeing to be here. And just a quick introduction to Dr. Heath. He has 30 plus years private practice in mental health, neuromechanical with a dual PhD in neuropsychology and forensic psychology. And he left us with this quote: "We first engineer our thoughts, then our thoughts engineer our lives." Dr. Heath, welcome. And can you introduce yourself or just tell us a little more about yourself, whatever you want to share with us?
The best pizza in the world has pineapple on it.
Exactly. And it was made in Canada. As a Canadian, I concur.
Yeah, we have a bit of a conspiracy going on from a group called Antipa, Antippa, which is the anti-pineapple pizza activists. And we're trying to root these people out because they're a real problem in our society today. But no, I appreciate you guys having me on. I do behavioral health every day. I do a good amount of what's called forensic psychology. If someone flies an airplane, drives a boat, a train, a big truck in the States, and they do something naughty that they shouldn't, then I'm kind of one of the gatekeepers that before they can get back on the road after using drugs and flying airplanes or driving trains, they have to go through me. So one of my jobs is keeping the roadways and the airways and the waterways safe for other people. And the rest of the time is just regular, treating everything from A to T, anxiety to trichotillomania. And you parents out there know what trichotillomania is. It is the irresistible urge to pull your hair out. So I'm sure every parent understands that. I think of myself as a neuromechanic. I'm not a diesel mechanic. I have a diesel truck, but I teach people how to reprogram how their brain works so they can have healthier lives and healthier relationships.
Wow. Thank you so much for that. Can you tell us how you got into this mental health field? What inspired you to enter the field of psychology, especially neuropsychology and forensic psychology?
I'm very curious. I like knowing how things work. I was the kid that took apart everything in the house to see if I could put it back together and to see what caused it to rattle and not work and things like that. I remember one occasion my dad gave me the little wires, antenna wires that fit on the back of a television back when TVs had antennas. And I thought that I would see what would happen if I stuck that in the outlet. You should never do that. That's a very dangerous thing to do. So it shocked me, of course, turned my hand black and everything. It was an unfortunate experience, but I just love seeing how things work, and so that's at the root of it all, is just kind of seeing how brains work.
Excellent. Thank you. Can you, I'm very curious. You sort of say like you help people kind of retrain their brains, and I'm familiar with cognitive behavior therapy. That's something that I've come across before. Can you sort of talk a little bit about the different types of programs that you use to help people, and what maybe kind of highlight a few of them and how they work and when they would be appropriate?
Yeah, it really depends on presentation. I typically do an assessment with a patient that may take um, a few sessions. One of the major mistakes that clinicians make is they try to get too much done too quickly, and if you try to assess too quickly, and by the way, on social media, you see people assessing all over the place. I often joke with people, goodness, if I'd only found social media and learned how to diagnose the social media way, I could have saved myself hundreds of thousands of dollars in student loans. All I need to do is go on social media and I can just diagnose people, you know. And so I see all kinds of diagnoses being slung around on social media. And but no, a good diagnosis takes time. It takes contact in a real space with a real person, face to face, often some objective assessment. And otherwise, there's a lot of, what we call type 1 errors. You think this is what it is, but it's not this. It's this thing over here. By the way, when I was at the VA, I did my clinical rotation through the VA. And this is, well, it's just sad. It's just sad, but we would have soldiers who were either male or female, and I kid you not, if it was a male that showed these symptoms, he would be diagnosed with PTSD. If it was a woman with the same symptoms, she would be diagnosed with borderline personality disorder or bipolar personality disorder, same symptoms. It's a rush to judgment. And so careful assessment takes time, and you have to be willing to see that you got it wrong. And then we really just, I try to fit what I do personalized to the patient, because the worst kind of treatment is a cookie cutter approach. But you'll see people that they have their favorite diagnoses. And so everybody is a narcissist, or everybody has autism, or everybody has PTSD. It's just bad practice. It's bad practice. So I try to make sure that I'm fitting the approach to the patient, and that's a slow process, you know. But as far as what works, um, I've changed my mind a lot about that, because I have found that what doesn't work is boiling a real life person down to a diagnosis. And instead of seeing the person, you're blinded by just focusing in on the diagnosis. I have, oh, I don't know, a stack of manuals, a stack of books over there full of diagnoses. And none of those books contain a person. They just contain a bunch of labels. So I think one of the major things we do wrong as a profession, psychology, is the labeling thing. And so one of the things I don't do is I really don't spend a lot of time diagnosing here lately. I have people come in and they'll say, I'm this diagnosis, that diagnosis, and I'll say, well, or they'll say, I'm ADHD. Really, your ADHD is what is that? Your genetic categorization? That's your genus, your phyla. You're not a human. You're a ADHD? No, I think that you're a person that struggles with something, but you're still a person. So why don't we start there? Why don't we start with how you function? Why don't we start with thoughts that you have that may not serve you well, like thoughts of can't, or must or should, or thoughts of that you're worthless, or thoughts that you don't measure up, or thoughts that you'll never succeed. So one of the main approaches is really back to the neuromechanics aspect of it, which is teaching people the mechanics of their own brain and how they are the authors, literally the authors, the script writers of their own reality. Because what you practice in the brain becomes the reality that your brain projects out there on the world around you. So it really gets down to thought processes.
Thank you. Thank you so much for that. And as I'm listening to you, and please correct me if I'm wrong, your approach does not line up with the DSM-5.
Yes, often it doesn't. Often it doesn't, because, the only thing better than a book of 167 or 68 pages, I forget how many pages the DSM-1 had. I have a copy over there. It was a pamphlet. Is a book of nearly 1,000. So there's a lot of money to be had in labeling human beings. But then we found that through confirmation bias, you kind of get what you're looking for. As a matter of fact, there's some great research in this area. One of my favorite was Rosenthal. It's called, hence been labeled the Rosenthal effect or the Pygmalion effect, where a group of teachers, and some of you listening to this may have heard me tell this story before, but bear with me, some haven't. But Rosenthal took a group of teachers and said, we're going to assess this classroom of students. And he gave them an assessment and he categorized them. He said, this group of students can be expected to have behavioral difficulties and to be low achievers. This group of students can be expected to be perfect behaviorally, do really well, and be very high achievers. Well, guess what? That's exactly what the teachers found. The teachers found almost exclusively what Rosenthal told them they would find is exactly what they found. But guess what? The research participants were not the students. The research participants unknowingly were the teachers. It were the teachers that were being examined, not the students, because Rosenthal took the stack of so-called assessments home and dumped them in the garbage. He never looked at them. So the teachers literally began to see those children how they were told they would probably see them. And that's the problem with diagnosis. Once you label somebody as having this diagnosis, your brain really focuses in on that and you're unable to see anything else. And guess what? They also are unable to see anything like that. One of my favorite books called The Center Cannot Hold, written by, I can't remember her name. Ellen Sachs, ElynSaks. Well, she tells a story of when she was a young lady, I think a teenager, where she had an experience that she described as the center could not hold, where her world began to spin around her. And it was an experience of depersonalization. She didn't know what was what. And then of course, it was, prodromal symptoms of schizophrenia and all that. So she began to have this experience, and then her life kind of went down the proverbial rabbit hole. But she said this, of all those things she suffered, all the failed treatments, all the failed medications, all the side effects, she said the worst aspect of that whole experience was none of that. It was going from being seen as a person to being seen as this thing called a schizophrenic, because there's no such thing as a schizophrenic. She would say, I did not become a thing when I developed this condition, nor does someone ever become, quote, autistic. And I'm a big advocate of de-labeling people and truly seeing them as people. One of my favorite philosophers Jean-Paul Sartre was big on that also, French philosopher, existentialist philosopher, who spoke a lot about how we dehumanize each other by labeling ourselves and labeling each other. He uses the example of a waiter. He says, even in seeing this human that you label as a waiter, that person has become less. And by the time they get to your table, they're not human at all. They're just this thing called a waiter. So that's why another favorite philosopher of mine, Soren Kierkegaard, actually had put on his tombstone, not a pineapple pizza, by the way, but a real tombstone. He had put on his tombstone what the individual, because he saw that the highest thing that we can ever be is not a diagnosis, not a political party, not any other label, but a human. So he had inscribed the individual. So I'm very much Carl Rogers, person-centered therapy. Let's start with the person. Unconditional positive regard. Let's start where you are. Let's hear about your reality. Let's really dig into the way that you think, and the way how you think determines your reality. And then we go from there. Either your treatment plan, your thought-based treatment plan, we all have one, is serving you well, or it's not. And then once we collaborate and see how well it's serving you or not serving you, then it's your choice, not mine, not the clinician's. The worst thing that a clinician does is tell people how to run their life. And for those of you listening, if you're a clinician, not to be critical, but you need to understand, from guys done this for a long time, it is unethical for you to tell people what to do with their life. That is their job. That is their place. It is unethical for me to tell people to stay married. It is unethical, and lots of clinicians do this. Well, you just need a divorce. That's a no-no. That's in the code. There's an ethical code, and that's against it, And so it's our job to help people take their power back, and that's why, Sharmin, I love what's behind you right there. The word empowerment, I believe is that word. Yes, inspire and empower. I cannot empower a patient if I'm making their choices for them. And that's a mistake a lot of rookie clinicians make.
I have so many questions, but Dr. Heath, is it a mistake that clinicians are making, or is it the way that they're trained and the expectation of the clinician?
That's a great point. It's really three things. It is that, yes, there are faculty members, professors of psychology, of social work, of counseling, and they have their what would you call them? I don't know, pet peeves or whatever, and they'll be far too directive because they're really trying to, I don't know, they're letting their own personal biases show through. The other thing is every clinician has their own personal bias. I'll have people ask me, they'll say, well, what would you do? Well, my response is, wow, that's a very interesting question. What leads you to ask that?
Mm.
And what if I were to say this? What would you think about that? And what if I said I would go this way? What would you think about that? My point being, it doesn't matter what I would do, because I can't live your life. I can't step in your shoes. So that's something that I'm not going to do you a disservice, because, it gets back to the saying, you can feed a person a fish and feed them for a day, give them a fish and feed them for a day, or you can teach them how to fish and they can feed themselves for a lifetime. The problem with a lot of therapy, where people go to therapy for decades, is they go to a clinician who is not a very talented technician, and they become dependent and they never learn to fish for themselves. Our job as clinicians, I think, is to be a bit of a Nanny McPhee, who told the incorrigible children in that great movie, who said to them, When you need me, but do not want me, I must stay. When you want me, but no longer need me, I must go. So our job is to work ourselves out of a job. And as a clinician, if I'm not working myself out of a job, I'm a very poor technician.
Wow.
I take it that process of working yourself out of a job, so to speak. I mean, it can really vary with someone depending on whatever's going on in their life. For some, that might be a month-long process. For some, that might be a year-long process because of whatever it is that's going on in their life. What are some of the um, tools that people can use themselves, or um, habits or things that somebody could do, for example, if they feel themselves under stress? Like, are there any sort of things that you kind of recommend to somebody if they're, happen to be stressed? Like, I know, like, some people like, squeeze a stress ball or do other things. Like, are there certain things, depending on what is troubling the person, that are good things for them to do to try and help work through that type of a stress?
Well, absolutely. Step number one is to understand stress. And I'll explain it this way. You can thank my profession for getting this wrong. And we've got so many things wrong, and I think we should be accountable to that. So we used to say stress was a killer. We used to demonize stress, and many still do. And whatever psychology said, 20 years ago, is the current mindset. So there's about a 20 to 30-year lag between current research and current belief system. So you can still see people demonizing stress. But let me provide an example of stress. As the three of us sit here, the weight of the entire planet is pulling on our body. The stress of the entire planet is pulling on our body. That's stress. As I lift this cell phone, it is exerting a stress on my hand. Is that bad? No, I don't think so. When I go to the gym and lift a weight, when I walk to the mailbox, there's stress of the friction of the gravel. I have a gravel driveway beneath my feet. If the wind is blowing 30 miles an hour, that is a stress of 30-mile-an-hour winds, or here lately it's been 40 or 50 against my body. Is that bad for me? No. So what the research shows is that, interestingly, although people with high levels of stress were followed and we saw adverse outcomes that were attributed to stress, we found people with really low levels of stress had the same adverse outcome at the same frequency. Now, think about that for a moment. If the same outcome statistically exists for people measured with high stress and low stress, it can't be the stress. So then we added another factor. And the factor, guess what? Was how people thought about the stress. So people with high levels of stress that catastrophized it. That's your new listeners, your new $5 word for the day, catastrophizing. What do you think? Catastrophizing. Yeah, $5 word. My dad used to say 5 syllables, $5 word. So the people that catastrophize stress died more quickly than people with low stress. But people with low stress who also catastrophize stress died at the same rate, died just as early. On the other hand, people with high levels of stress that did not catastrophize it, it had no statistical effect on them. So it's not the stress, it's how I decide to think of it. So the first thing to realize is that stress is a normal part of life. Stress is the weight of existence on my life. There is no life without stress. The phone ringing, stress. Bright lights, stress. A bill in the mailbox, stress. A disagreement with my spouse, stress. And none of those are bad. That's just part of life. What can make them adverse to us is how I decide to look at it. If I program my brain to believe it's a catastrophe, if one of my favorite psychologists, Albert Ellis, would call it awfulizing. If I awfulize it, then what that's going to do is ramp up fight or flight mechanisms in my body and my brain that have a wearing, tearing effect on my life. If I decatastrophize it and look at it like, well, that's a lot to do. Having a lot to do doesn't make it a bad day. Goodness, every day above ground is a good day. So difficult does not equal catastrophe. And I find in my clinical practice that although there's a catastrophe scale of 0 to 10, to lots of people, every non-preferred event is a 10. Everything becomes a 10. Everything becomes a catastrophe. Well, those people will die more quickly. There's lots of things that I don't prefer, but I know how to engage in self-care. Here's one. It's simple. This is my nice, lovely apple cinnamon tea. I like to sit and sip it at different times throughout the day. I focus on my breathing. I do mindfulness exercises. I do cardio exercises. Tomorrow morning, I'll get up and do a cardio exercise. I do resistance training exercises. They're very difficult, but see, they do make me more resilient. And when I do have a stressor, take that word apart, stress or. Well, I love to kayak. It has an oar. So a stressor is just the oars of my life in the waters of life. Well, that's normal. That lets me know I'm alive. I got to have something to do. I have to feel life with some meaning. And so I can assign meaning and value even to stressors and then engage in self-care. I have a healthy diet. I'm not a obsessive compulsive about it. On the weekends, on Saturdays, I'll kind of knock off and eat 2 big bowls of air pop popcorn with, pizza flavored sprinkles on one and on the other birthday cake sprinkles or something or other. It's high fiber and it's really tasty. So I treat myself to things that I like, and I may sit and veg out on a Netflix series or something like that. So self-care. So people talk about getting rid of the stress. The only way to get rid of stress is to delete things from your life. Well, how much can you do? If your life, I don't have a book with me, but if your life, here's what would happen. If your life is a book about this size and you go to the page that you like reading the least, oh, I wish I could just rip this page out of my life. And you rip that page out of your life, you know what's going to happen? Another page will take its place. So the next most difficult thing you will then assign as the most difficult thing. Well, that's okay. Rip that one out. And then the next most difficult thing will become the most difficult thing until you've removed so many pages from your life. It is not a book or a novel, but a pamphlet. Actually, removing difficult things from our life just leaves us with what? Less of a life. And I don't want less of a life. Give me all of it. I'm here for the whole show. So my top, stress management technique is learning to value things, even if those things are non-preferred or difficult. So I hope that helps a little bit. You can follow up if you have a question there.
Okay.
Well, okay. That was excellent. You've given us so many tips. You've shared your own self-care techniques with us, and mindfulness, drinking tea, the physical, all of that. Thank you for that. How does neuropsychology, let me rephrase that. Yeah, how does neuropsychology relate to let me say, the two most diagnosed mental illnesses, depression and anxiety?
That's a great question. Usually, neuropsychology is drawing inferences from experiences to the cortical, neocortical, the jigsaw puzzle pieces of the brain. And it was really the father of neuropsychology was Alexander Luria. He was in a hospital where, unfortunately, he treated lots and lots of soldiers from the war who had severe head injuries. And he noticed that if you had an injury here, there's things that you couldn't do. And if you had an injury here, there's things you couldn't do. For instance, maybe you could understand what I'm telling you, but you could not respond. Or maybe you could respond, but since another area was not working well, it was gobbledygook. And so there's really a correlation between different areas where you may find a lesion in the brain and reduced capabilities. I don't typically, there are guys that do that. My colleagues do that. As a matter of fact, a lot of neuropsychology has a big forensic psychology component because we can kind of estimate what your ability should be, let's just say at your age, you ladies' age, and where you should be cognitively versus where you are after a head injury based on a car wreck. And then the difference of where you should be and where you are, to put it bluntly, is worth something in a court of law when there's a liability lawsuit. So a lot of neuropsychologists for that reason. It's also to diagnose, organic syndromes like dementia, Alzheimer's, ADHD, many types of disorders. What I use it for, again, is trying to teach people how to be a better mechanic of their brain. Here's an example of that. In social media, there's a big thing about discipline. What is discipline, or where do you get discipline? And, what bottle of discipline elixir can I get, and what program can I get on? Well, there are neurological pathways that help us with motivation and discipline. And here's a tip. There is a pathway that listens to whether you keep commitments to yourself or not. It listens very closely. So if you make a commitment to yourself, let's just take a New Year's resolution, or let's just take a promise to someone. I promise you I'm going to do this, and you don't do it, then your brain will get better and better and better at not keeping commitments. Literally, you have taught your brain to not follow through with a commitment. So for me personally, since I don't want to do that, if I say to myself, I'm going to go into my workout room, it's right over there. It doesn't matter how tired I am. It doesn't matter the hour of the day. I try to make it between 10 and 10:30 at night. My wife is in bed. The house is quiet. I listen to some good music and I do my workout. But there have been days I've been so busy, it has been midnight. But since I don't want to sabotage myself, I will still do it. And I'll be clear about this. It's late. I've had a long day. I'm really noticing how very tired I am. I think, oh my goodness. And I start catastrophizing. Oh my goodness, I'm so tired. I just want to go to bed. Oh, don't I deserve to take a night off? Don't I owe it to myself to just get more rest? See, I still have all those thoughts. The brain creates thoughts the way blizzards create snowflakes. A thought on its own is meaningless until I decide what meaning that thought has. So therefore, the thought of I should just go to bed, I literally grab it as if with a teaspoon. TSP, teaspoon, thought selection process, TSP, thought selection process, the teaspoon technique. I grab with a teaspoon and I lower it down here. That thought has no value to me. That thought doesn't serve my life well. So since I'm so tired, since I'm so exhausted, since I'm hearing I owe it to myself to go to bed, since I have all these sabotaging thought processes, what do? I go work out. I keep my commitment to myself because my mind is on that, it's called the mesolimbic pathway. And I'm trying to energize that pathway so that I become an expert. I'm an Olympic athlete at keeping my commitments to myself. And that's where neuropsychology comes in with patients. I teach them how to maximize, I'm a believer, God created pathways in the brain to maximize how those work and maximize their lives and maximize their success. And so hopefully that kind of answers that question. If it doesn't, go ahead and ask me another one.
It sure.
Well, I think you brought up a really interesting point there when you talked about keeping commitments to yourself, because I think that one of the things that I see in working with business owners and stuff is sometimes they make a commitment because someone else told them that that's what they should be doing, or someone else thought that was a good idea, but it wasn't really something that they believed in or wanted to do. Or so they said that they were committing to it, but they weren't really committing to it because it wasn't coming from within, so to speak. And so can you sort of talk a little bit, and then of course, sometimes you may make a commitment to yourself, but then at some point, something in your life might change, and whatever that particular thing that might have served you really well for a period of time, it might not be serving you really well anymore because something has changed, and you may have to adjust your commitment. So like, sort of, how do you know when it's sort of a case of, okay, it's not serving me well anymore, so I need to make an adjustment in what that commitment was, versus you're giving up and you're not holding your commitments?
Absolutely, absolutely. And I call that a treatment plan. You don't have to go to therapy to have a treatment plan. Let's not kid ourselves. All of us have treatment plans. Some of us, our treatment plan includes when we're experiencing undesired emotions, emotions which we don't like, emotions which we don't prefer. Quick tip. You can thank my field for demonizing emotions. You know why we have these emotions? Sad, mad, glad, disgusted, ashamed, stressed, depressed, anxious, angry, pleasure, joy, fear. You know why we have them? We are engineered with the ability, with the capacity to have these emotions. None are bad. None are negative. None are harmful. You will never see on a death certificate cause of death, anger. Cause of somebody else's death, anger. Nobody dies of anger. Nobody dies of being angry. Nobody dies because somebody's angry at them. Now, you might die because somebody hit you in the head with a toaster oven, but that's a behavior. So one of the things I encourage people to do is to differentiate between what you feel and what you think. Those are two very different things that people get them mixed up all along. But let's go back to treatment plans. Here's a treatment plan I have, and it was a healthy one. It was a healthy treatment plan. It was my workout. So I'm gradually increasing weight on my workout, slowly, carefully. I'm a very careful lifter, very, very fluid and careful and everything. But whatever happened, I got an ulnar nerve injury. It's difficult. And I could have persisted and went ahead, and it's very hard to change patterns. Even though my pattern was to work out every night, I don't want to be foolish. And so, yes, for a week, I took off to give my body time to heal, time to rest. And here's why I did it. I was talking with my son who's in med school, and we kind of figured this out. And I said, well, let's talk. What's the worst thing that could happen? Well, if you rip that particular nerve, there's really no way to reattach it. Well, that sounds terrible. I don't want to do that. Don't sign me up for that. So, it taking off, resting had more value than pushing my body to a point or I will gain an injury that's going to set me back months, And I did. I rested, and I'm now building back up to where I was. But yeah, that's a good point. Another one is, yes, maybe the world changes, maybe a job changes. It really gets down to what I will call a values matrix. And so I encourage people to sit down on paper, write down these things that you say are important, and then assess what level of value. Here's a big one. Let's just take New Year's resolutions. You'll have people say, I want to lose weight. Okay, that sounds great. My baby sister said that to me. That sounds great. How can I help? Well, I don't need your help. Okay, let me know if you do. Take care of yourself. So I want to lose weight. Well, that's here. But wait a minute, not so fast. We have other things we value over here, like that big tub of ice cream and sitting on the couch and hanging out with friends, eating everything they eat, and just the pleasure of having that food in their mouth. Well, if these things have a higher value than health will take a back seat to those. What a wonderfully beautiful kitty cat. What is kitty cat's name?
Snickerdoodle.
How old is Snickerdoodle?
Snickerdoodle is about 8.
Oh, my word. No spring chicken, huh? That's great. So my point here is whichever thing has most value is the thing we'll do. So it's not motivation. And by the way, motivation is not a feeling. Motivation is not a feeling. Motivation is based on our values. So if sitting on the couch has more value than being in good shape, we'll sit on the couch. And so I believe that we should be very honest with ourselves. Our feet always follow our values. I'll say it one more time. Our feet always follows our values. And this is to your example when you were talking about the business owner. The business owner that commits to doing something and they don't do it, it's because what they committed to doing, they didn't first assess the value of doing it. And since it had a lower value than something else, they did the something else.
Our time has gotten away from us, and this is such a rich discussion. But as a neuromechanic, what tips can you give a patient whose therapist or clinician is not a neuromechanic, but they want to become a neurotechnician? What tips can you give to them?
I would recommend leveraging that person's skill set in terms of keeping them accountable. I would encourage them to come up with a treatment plan that serves their life. I would encourage them to sit down on a piece of paper and specifically write down their goals and the value each one has, and take one at a time and make themselves accountable to that clinician, and to say, this is what I'm committing to. I'm going to come in each week and talk to you about this. I'm going to tell you the steps I've taken, and I want you to call me on the carpet, hold my feet to the fire when I don't measure up to what I said that I would do. Because, by the way, I tell people I'm a therapist, but I'm not a massage therapist. That's down the road. Real psychotherapy is not a massage. If you want a massage, don't go to psychotherapy. And if all you get from psychotherapy is a verbal massage, you're probably going to love it, but you're not going to get a lot of use out of it, utility out of it long term.
Wow. Thank you. Mitzi, before you close, do you have any other questions?
No, it was really interesting sort of listening to what you shared, of sort of the way I'm looking at some of the different situations. So I found it quite enlightening.
Thank you, guys. I really appreciate you having me on. Great show. I love the graphics. I love your setup, and I think you'll do well. If there's any way I can be of assistance in the future, don't hesitate to reach out.
Thank you very much for helping us transform lives.
Thank you.
And how can our listeners, it said they want to contact you, they want to reach you, where can they reach you?
I'm on X at therapy_bites. We're taking a bite out of therapy at therapy_bites, and just follow along. I do a daily show, a daily space called Midday Mindset. We take a different topic every day. Every Wednesday is Hump Day AMA. So Hump Day, Ask Me Anything, and that'll be tomorrow. It is always 12 p.m. Central Standard Time. That's Memphis, Chicago time. So just welcome you to follow along.
Thank you so much. And this has been a great episode of Transforming Lives panel podcast, and we'll see you next time.
Thank you so much for joining us today on Transforming Lives panel podcast. We hope that you received some nuggets of wisdom and seeds to plant along your journey of transformation. If you enjoyed what you heard today, we encourage you to let us know and to share us with those that matter in your life. If you would like to connect with anyone from the panel or our guest speaker, you can find all of the ways to connect in our show notes. We have so much gratitude for you, and we are so thankful to be a part of your day. Until next time, take great care.